This module describes practical aspects of the brainstem auditory evoked potential, and we'll talk about patient condition and parameters, stimulation parameters, the recording montage and recording parameters, as well as the brainstem auditory evoked potential waveforms. The brainstem auditory evoked potential, or BAEP, has several names. It can also be called the auditory brainstem response, or ABR, or brainstem auditory evoked response, BAER, or BAER. All three of these names refer to exactly the same thing. They can also be called an AEP, or an auditory evoked potential, but it's important to note that the auditory evoked potential can refer to either the brainstem evoked potential or a cortical auditory evoked potential. And what we record clinically is only the brainstem response. And so it's important to differentiate the auditory evoked potential, whether it's a brainstem or a cortical, if one is asked just for an AEP. Now, the BAEP, the brainstem auditory evoked potential, provides a means for us to assess the integrity of the eighth nerve or the acoustic nerve, and also the auditory pathways of the brainstem. Now, it's important to note, and I can't emphasize this enough, that the BAEP only assesses brainstem function, and so we cannot assess cortical function with this response. There are three types of auditory evoked potentials. The first type are short latency auditory evoked potentials, and these are what we see in the clinical EP lab. And so these are the ones that are generated in the brainstem that have peaks 1 to 5 and have a very short latency. They occur within 10 milliseconds. The second type of auditory evoked potential are the middle latency AEPs, and these occur after peak 7. And so their latencies are between 10 to 50 milliseconds, and they have very, very tiny amplitudes. And they probably reflect activation of the pathway between the thalamus into the cortex. And then the long latency auditory evoked potentials begin around 50 milliseconds, and they have slightly bigger peaks, up to 10 millivolts. And they represent activation of the auditory cortex. And so again, in our lab, we only look at the short latency AEPs, or the brainstem auditory evoked potentials. Since brainstem auditory evoked potentials are used to look at the integrity of the brainstem, they're helpful if there is a suspected structural lesion or demyelination in the auditory pathways of the brainstem or within the posterior fossa. Brainstem auditory evoked potentials can also be used to assess hearing deficits and hearing thresholds, although in our lab at Sick Kids we try not to do this, and we refer the patient to audiology for this kind of testing. And this is because audiology can do a more detailed test than what we do. The brainstem auditory response will not be normal if the patient does not have normal hearing, or if there's anything that's obstructing the peripheral hearing system, obstructing the ear or the outer ear, or if there's any sort of infection or fluid in the middle ear. The brainstem auditory response is a very small amplitude response, and so it's very easily obscured by muscle artifact. And so the patient is usually tested lying down with the head and neck supported. The patient needs to be quiet and still, and the neck muscles and the jaw need to be relaxed. Patients can be tested while they're asleep, and patients who cannot lie still will require sedation. For the brainstem auditory evoked response that we record at Sick Kids, we stimulate the patient with clicks that are delivered through headphones. The clicks are delivered to one ear at a time, and in the other ear we play a masking noise, a white noise masking, that prevents bone conduction of the stimulus to the other ear. Each ear is tested separately, one after the other. The click is something called an alternating polarity click, which we will discuss in more detail in the module on stimuli. And then the clicks are presented typically 8 to 10 per second. There are 1,000 to 4,000 trials, so there's a lot because it's a very small response. And then typically the stimuli are presented between 70 to 90 decibels, SPL or sound pressure level. And we'll talk more about sound pressure level and other hearing scales in the module on stimulation. So once again, the patient is tested sedated, asleep, or lying very still. The recording montage of the BAEP consists of 3 electrodes. One electrode is placed at the vertex at CZ, and the other 2 electrodes are placed at the ears, either on the earlobes or on the mastoid process behind the earlobes. Now from these 3 electrodes, we get different montages. And so depending on the ear that's stimulated, the montages will tell us different things. And so the stimulated ear, for the different montages, the stimulated ear is the ipsilateral site. And so one montage is CZ reference to the stimulated ear or the ipsilateral ear. In this diagram, it's the left ear. The second montage is CZ to the contralateral ear. So it's the ear that's not being stimulated and it's receiving a masking noise. And then the third montage that we do at sick kids, but is not typically done in adult institutions, is ipsilateral ear reference to contralateral ear, or AI reference to AC. The recording parameters of the BAEP are pretty straightforward. There's one set of parameters for neonates and children under 6 months of age, and there's a separate set of parameters for everyone over 6 months of age. And so for neonates under 6 months of age, the stimulus rate is 7 per second. We go nice and slow. While for those above 6 months of age, it's 8 to 10. We typically use 9 stimulations per second. The sweep time is longer in the neonate group, and so it's 20 milliseconds, and the sweep time is shortened in those over 6 months to between 10 to 15 milliseconds, shorter for older. The number of trials for both groups is between 1,000 to 4,000, and the technologist would make a decision based on the appearance of the waveforms as they are acquired. The bandpass is wider in neonates because the responses are of lower frequency, and so the bandpass is 30 to 3,000 hertz in the neonate group and 100 to 3,000 hertz in the older group. The standard recording montage where the BAEP is seen is CZ to ipsilateral ear. And so with this montage, we typically will see 5 to 7 waveforms. The waveforms are labeled with Roman numerals 1, 2, 3, 4, 5, 6, 7. And these 7 waveforms will occur within 10 milliseconds of stimulation. Now, waves 1, 3, and 5 are considered obligatory. That means we must see them for a normal response. There's lots of variability with the appearance of waves 2 and 4, although we do typically see them, but they can look quite different and they can be smaller. So what we're most interested in is waves 1, 3, and 5, and we do our latency measurements on these 3 waves. Now, sometimes wave 4 and 5 can be fused to form like a plateau, and so wave 5 would be the back end of the plateau. And then often waves 6 and 7 are not seen, and so they're not obligatory, and they're much smaller, so they're often not seen even in a normal response. Different recording montages will highlight different waveforms in the BAEP. And so the standard recording montage, CZ to the stimulated ear or to the ipsilateral ear, will show the best overall auditory evoked response. And so we need to see the obligatory waveforms of 1, 3, and 5. In the second montage, which is CZ to the contralateral ear, the wave 5 shows up the best. And so the most prominent wave that we should see in the response is the wave 5. Now in the final montage, the ipsilateral ear to contralateral ear, this recording is typically not done in an adult institution, but we find that with children and smaller heads, this tracing is actually very helpful, especially in the neonates. And so ipsilateral ear, stimulated ear to contralateral ear gives us the best wave 1. And so by using the second and third montages, if the first montage is not so clear, the second and third montages can help us identify the most prominent 5 and the most prominent 1 so that we can sort of trace back to the first montage and identify what might be the 1 or the 5. This will become clearer as we start to look at some case examples.